All right, so insulin drips. So again, this didn't fit when with pressors or sedation, so we're gonna little tag on with insulin drips. And insulin drips are going to be talked about again with endocrine. So we'll talk about diabetes and DKA and HHS and all those things. And it might make a little more sense to fit in over there, but we needed to tell you about it now because insulin drips, they often get titrated incorrectly, even though now it's all computerized, right? Back in the day, it used to be all on paper and you had to use math, right? They say, hey, go up by 150%. You're like, what? How do I do it? I reduce the rate by 50%. And people are like, they went from 6 to 1. It's like, well, how do you get in? That's not half, right? So it'd be 6 to 3. And then you start getting decimals. Is that 1.5 or do I go to 2? And my pump only goes to, then there's a whole bunch of issues that would develop with insulin drips, right? But insulin drips, like anticoagulants, have to be witnessed, right? And what's the thing with anticoagulants that was different than every other drip?
Pharmacy.
Yes, it's pharmacy, but every single titration has to be witnessed by another RN. So like Levophed or dobutamine or those other drips, when you go from 4 mics to 2 mics, you go from propofol 50 mics to 45 mics, you don't need someone else to witness that for you. Insulin drip, you do. Heparin drip, you do. All right, so the only 2 drips that require an RN for every single titration. But this is titration that does not require pharmacy, unfortunately, right? So so if you go from insulin drip at 2.4 units an hour to insulin drip at 1.8 units per hour, you better have someone witness that that was the correct titration, okay? So DK and HHS, those are complications of diabetes, and we'll talk a lot about diabetes and endocrine. But then we have critical care insulin, right? One of our pressors causes hyperglycemia. Which pressor was that? Epinephrine. So someone's on epinephrine infusion, right? They're going to vasoconstrict to the periphery, and giving sub-Q insulin is not going to cut it. So you probably need to give IV insulin. And we want our sugar under 180 in the ICU to begin with, so that our white blood cells can function in septic shock, and also we can have recovery. So it's a lot of good things happen when your blood sugar is under control. And just for the same reason, CABG patients also need to have their sugar under control so they have good wound healing afterwards, after their open heart surgery. All right, so how do you know which one to do? Just search advisor, and you're going to find one of those 4 options, right? And you just got to figure out what situation you got in front of you. Do you have an open heart patient? You would know if you have an open heart patient, right? And do you have an ICU patient? Yes, I do, but are they an ICU patient who has HHS or DK? So you can read the progress notes, kind of figure out which one it is. But the most common insulin advisor that we're going to use is DK. Right? When a patient comes in with DK, we're going to be giving insulin to get their sugar under control. Right? So the reason for critical care is because, like we mentioned, white blood cells don't work when their sugar is over 200. Right? We have glycated hemoglobin. You have glycated vessels with a crystallization of our vessels, crystallization of our nerve endings, causing neuropathies. You also have crystallization acutely of your white blood cells. It directly impairs our white blood cell function, our immunoglobulin function. It doesn't make us be able to mount an effective response as well as if our sugar was under 200, right? So the other piece with glucose and IV insulin, why we would need it is sub-Q is not going to work when we are all vasoconstricted. When we're super vasoconstricted, we're not going to get a lot of absorption in that situation, all right? So otherwise, we got to figure out what advisor to use. So if they're here for DK, you heard it's DK, you're going to probably start DK advisor, right? This usually gets started by the provider, but sometimes you have to, hold their hand, or you have to let them know, hey, can we switch to this one? Because I noticed you said HHS, or you ordered DK. You said in your note you wanted DK, but then you ordered HHS, so we had to switch it around, right? So DK protocol is to promote a safe drop in your glucose, about 50 to 100 points per hour. 50 to 70 per hour is kind of where we want that sugar to come down nice and slow, so we don't get a rebound cerebral edema. That's really more prominent in kids, but DK affects kids, and we get patients that are like 18 years old, 19 years old, 21 years old. So they're still susceptible to this change in glucose, this rapid change in glucose. The other point of the DK protocol is to recommend the appropriate fluids for a patient that requires a lot of volume resuscitation, because a DK patient and an HHS patient are extremely volume depleted. So we need to restore that volume, and we need to restore their glucose to normal value. Okay. So how does it work? It's based on a point of care glucose. So we grab a glucose, dock the meter, and then it uploads to the program, and it tells you what to do. All right. You'd think it'd be cut and dry, but then sometimes it makes some crazy recommendations. Sometimes we don't help the program help us, right? So like for IV fluids, for instance, how is it going to know, right? It's not that smart. The only way it knows what IV fluids you want to give is based on the rate you put in there. Say, hey, I want the fluids to be changed to be the fluids that are running at this rate, at 200, let's say. So that's the only way it would know. All right. And then it's based on the point of care glucose. And you all had your glucose module training, so you know that it doesn't give you a value if it's over 500. So what do you do then if I dock the meter and it's greater than 500? Is the advisor going to tell me? So no, it's going to say I can't give you a recommendation because I want to drop the sugar by 50 to 70 points, right? And if your sugar before was, let's say 800, right, on the labs, and now you dock it and it says greater than 500, is it 501 or is it 845, right? So you want it to be 845 because that's a nice drop of 50 to 70 points, right? So you want to have a nice steady drop. So it's not going to give you a recommendation. It's not safe. So how do you know what your sugar is? If it was 850 before, you need to get a lab draw. So labs sometimes is really annoyed at us because we're calling them every 1 hour. Say, hey, my sugar's high. Can you please draw it? Your sugar's high. So they need to keep doing that until the sugar is under 500. Okay. If they give us a point of care machine in the ABG room, be absolutely fine, right? No problem. All right, what else? So it's going to tell you about sugar dropping and, again, the fluids recommendations, right? Because if you don't want to give D5 half an S or D5 an S if someone's sugar is still high, but the sugar starts falling below 200, that's when we're going to start adding dextrose to our IV fluids. Okay, so like I mentioned, it's going to cause rock candying of the vasculature, of the neurons, of the white blood cells, of the hemoglobin, and we can measure the hemoglobin A1C in the future. All right, so a little overview of the advisor. It has two options. It has the protocol, and it has two phases: the initial phase, and then coming down here is off the screen, but we have initial phase and subsequent phase. So there's two phases to it. The initial phase is done in the ED, or if there's an RRT, it's done by us in the RRT phase, right? So there's an initial phase, and there's the ICU piece. So the ICU provider is the one that does the subsequent phase, and the ED provider is the one that does the initial phase. The initial phase is resuscitation. We're giving a lot of volume, and we're giving a lot of insulin to get them kind of resuscitated. And then after that, the reason why we do a subsequent phase, or when the subsequent phase is appropriate, is after we got a chemistry. So once we got a second BMP, then we can start getting some information about the subsequent phase. What are we going to do after we've resuscitated them? All right. So initial phase, fluid resuscitation. And just for every DK, HHS, the goal for them is to do Fee-Fi-Fo-Fum, right? So FIE. So fluids, insulin, and electrolytes. We know with insulin, we give insulin, what's going to happen to our electrolytes? Potassium is going to go down, right? So we always have to be alert to our electrolytes, especially mag and phos as well, right? So mag and phos can be depleted in great amounts in DK, right? And electrolytes in HHS, you can have a really, really high sodium. So there's different things that can happen, whereas in DK, the sodium is actually really, really low. So we'll talk about the reason for that, right? So fluid resuscitation is about 10 mLs per kilo. So you're giving not 30 mLs per kilo, but 10 mLs per kilo per hour. So you're giving, so if they weigh 60 kilos, that's 600 mLs per hour you're giving the patient. And that's up to 50 mLs per kilo in 4 hours. So for instance, we have a 60 kilo patient, that's 10 mLs per kilo per hour, so that's 600 mLs an hour, and we're gonna stop as soon as we reach 50 per kilo. All right, so that would be about 2.5 hours that we would get it done. All right, so then what else? You can adjust it for CHF and end-stage renal disease. And what fluids do you want to give? Not normal saline, you want to give LR, all right? Because especially someone in DKA, they are going to be acidotic in the first place, and normal saline is going to add to the acidosis. So it's not a great situation to be in. So FIE, so fluids, and now insulin, right? So insulin is going to usually give us a bolus, 0.1 per kilo, and then a drip started at 0.1 per kilo. So they weigh 60 kilos, that means you're giving a bolus of 6 units, right? Is it sub-Q or IV? It's intravenous, right? It's IV. It's regular insulin, the only IV form that we can give, intravenous, right? And then we start that drip, and then we're going to let it ride until we get another chemistry, right? And in the meantime, though, we're still doing Q1 hour sugar checks because the advisor will give us changes based on that sugar value. And electrolyte replacement, we mentioned K, mag and phos definitely get depleted as well. So we want to make sure that they're ordered initially, but also definitely in the subsequent phase. If you look at the subsequent phase here, our initial phase has it as well, but I think subsequent phase I have on the next slide, you has K protocol, MAG protocol, phosphorus protocol, right? It'll tell you what's, it'll give you options to replace them so that nursing can replace it at will, all right? And then hypoglycemia protocol. So you can get hypoglycemic if you get insulin. So we want to make sure that box is checked as well. And then BMPs are every 4 hours. So sometimes they'll do no BMPs, or every 6 hours, or just with the AM labs. Like, hey, we got 9 p.m. chemistry, we're just getting the AM labs at 5 in the morning. That's way too long, right? Your insulin can overcorrect, right? Or it can cause a drop in the electrolytes way too much. So we want to make sure that we are bringing things down slowly with the sugar checks, but also we are making sure we're not wasting electrolytes. All right, so then the subsequent phase. So now we are, we finished the fluid resuscitation part in the first 4 hours, but now we are, checking the chemistries every 4 hours and the MAG and phos and our electrolytes, and then we are, we're switching the fluids around. LR is preferred, but sometimes we have to have dextrose, especially for less than 200 on our sugar. That's when we're gonna start adding dextrose to our IV. And then what about why NS or half NS? So that depends on the sodium, right? The sodium is more than 140, we're probably going to add normal saline. If it's less than 140, we're going to do vice versa. If it's more than 140, we're doing half NS. If it's less than 140, NS, right? What else? So IV insulin is going to be adjusted every 1 hour, and then we're going to keep doing this until the decay is resolved. All right, so make sure in the subsequent phase, so we're in the subsequent phase now, that we have chosen our electrolyte protocols. They could have been, the boxes could have been checked in the initial phase. If you look at the previous slide, you can see initial phase, they had options to replace electrolytes. But want to make sure that this box is checked, right? This box is going to have the fluids that you're giving, right? The fluids that I'm going to be infusing to this patient over the next 24 hours, whatever it may be, until the decay is resolved. I want to make sure it knows which fluids those are, right? So I want, and usually it's a high rate, like 200, 250, 150 mLs per hour of fluid resuscitation that you're giving the patient after that initial bolus. So how's it gonna know? So this fluid right here is 250, this fluid is 250, this fluid is propofol insulin, and we got this is at 25, and this is at 125. What do you want your protocol to adjust? Right? Do you want to adjust the normal saline, the D5NS, or the D5 water? Right? How is it going to know? The only way it knows is based on this rate. So we got to plug in 250 there. So it's going to make adjustments on these two, and it's going to get confused. It's like, which one do you want me to change, bro? All right? I got two 250s here, so you let me know which one you're infusing right now, because it thinks you're infusing whatever's on the MAR. Right? It has no idea otherwise. So you have to let it know which fluids are going to be the ones that are going to be given. Okay, so the DK IV fluids rates on the subsequent phase right there needs to match which fluids on the MAR that are going to be given. Okay, and then make sure your boxes are checked for the electrolytes, so that way we can give the electrolytes. And we're checking this anyways with our chemistry. Remember, our basic metabolic panel does not have the MAG and the phos, so that has to be added on. And then IV fluids. So again, IV fluids is going to know which rate to change, but what about the content of the fluids? What if it's dextrose or NS or whatever it may be, right? So how does it know? It basically says if your sugar's on 200, I'm adding dextrose, right? Sugar's on 200, add dextrose, and then what about if the sodium is high or low? If the sodium is high, I'm going to make it half NS. If the sodium is low, I'm going to do NS, right? But it's the corrected sodium. It's not the actual sodium that's being measured, because your sodium gets diluted out by glucose, because where glucose goes, water goes. And that's going to dilute out my serum because my glucose is so high in my serum, right? So it causes a dilutional hyponatremia. You never get concerned when the sodium's low in a DK patient. You're not going to call the provider, power call them, power dial them, hey, tell a telemarketer, hey, sodium's low, sodium's low, sodium's low. They don't care. All right, the sodium's low because the glucose is high. If it's still low once the glucose is under 200, then that's a problem. Okay, so corrected sodium is about 2 MEQs for every 100 rise, right? Above normal, right? Above 100. So if my sugar is 1,000, that means my sodium's off by how many points? It's about 9 points, right? So over 100, so 100 to 1,000, right? Every 100 over after 100. So that's 9 100s. So it's off by about 9 MEQs. So my sodium normal 135 to 145, let's say it's like 137. My sodium is 128 at this point with a sugar of 1,000. right? So we can calculate the corrected sodium. You just punch it in MD-Calc. I think it's in your in the Cerner calculator as well. So that will give you a actual corrected sodium value. So how do you know you're done with DK? How do you know it's all done, right? So we'll talk about this more in endocrine, but why this makes sense. But you're going to have a acidosis that's resolved. How you know your acidosis is resolved is because your bicarb is correcting, right? Your bicarb is going back up. And then you have a CO2 value, which is your bicarb, but you also have the anion gap. And we'll talk about how to calculate anion gap as well, but that tells you how many acids basically you can't measure. And so you can measure ketones, but it's not like a one-to-one. So when your acidosis is resolved, your anion gap gets closed. So anion gap at 12 or less, your bicarb is good, right? 15 plus, I'm going to say 18. And the pH, if we got a ABG or VBG, that's more than 7.3, that's going to be a corrected DKA. You just only have to have 2 of those, right? So 2 of those options and your sugar is under control, we can take them off insulin drip. So how do you take someone off insulin drip? You just turn it off and call it a day? Well, no, because they're going to go right back in the DK if we don't do this process, right? Just like with our diltiazem, right? It might try to bounce right back into AFib RVR if we don't start something PO for diltiazem. For insulin, similar concept. We have IV, and then we start something basal, and we give keep doing AGACNP maybe every 4 hours if we're worried about them, or maybe ACHS, right? We're doing it before meals and at bedtime. So we have the IV insulin, and what they're going to want to know is how much insulin they get in the last 24 hours. So whenever you ask, hey, my DK is resolved, the next question out of their mouth is, okay, great. How much sugar, how much insulin have they gotten in the last 24 hours? Because that's going to tell them how much long-acting insulin to get, right? Your long-acting insulin is your insulin that is your basal. That's what's going to suppress your sugar by 10% or 20% over 24 hours, right? We got to make sure we don't bring it down too much by 90%, right? We want to make sure that we're bringing it down by a certain amount. And that amount is based on the last amount of insulin they got in the last 24 hours. So that is usually about 80%. So if they got, 40 units of insulin over the last 24 hours, right? What's 80% of 40? Well, that's mean, right? 10% of 40 is 4, and 4 times 8 is 36. So that's about 36 units of insulin that you're going to be giving to this patient, and they're going to give that 36 units, and they're going to dose it per BID, or they might give a certain, they look at the patient, hey, you're type 1, yeah, you can tolerate more basal insulin. If they're type 2 and if they're thin, maybe not 36, that's a lot. Or if they are more obese, you might change that value up a little bit. But that's kind of the ballpark of how they're getting a basal insulin coverage. All right, so they're going to do basal insulin and also prandial insulin. Prandial means with food, right? They're going to give insulin with their meals and do ACCHECs with their meals as well. Okay, so going back to fluids, just a little pro tip: when you have fluids running, sometimes your sugars, is 180, and it says, hey, switch your sugars to D5NS, right? You're like, okay, got it. And you switch to D5NS. The next sugar is 210. Okay, switch your fluids to NS. You take it all down, you spike the new bag, you spike NS. You're like, well, shoot. So the pro tip is just have both there and just pause it. You pause one and start the other one based on whatever your sugar is. Does that make sense, right? That way you're not spiking bags left and right, and you're like, you drive yourself crazy. All right, so hourly changes. What are you doing hourly in the meantime? Right, you're docking your sugars, right? You get your sugar, and then you dock it in the dock. It uploads to the record, and then it's going to compare the previous hour's sugar and the current hour's sugar. And it wants a drop of how much in DK? It wants to drop about 50 to 70 points, right? So if it's not, it's going to adjust your insulin. Say, hey, you only went from, let's say 400 to 375. I want that to come down a little bit quicker. So what am I going to do? I'm going to make you increase your insulin by 50%, right? And this is where we got thrown off back in the day when we had to do it on paper. Increase by 50%. What's 7 times 50%, right? So was that 10.5 or is that 50% like 0.5, 7.5? You got some really weird math that happened back in the day. So you'd have now it tells you, say, hey, your sugar was 174, now it's 168. You're going to increase or set the insulin drip rate to 1.4, right? So it's currently at 1.4. You can just keep it nice and steady at 1.4. As long as it's under 200, then that's kind of where we want it at. We just want the insulin to fix the DKA on the back end, right? So once you do that, you click submit, it's going to give you a recommendation, and then you have to show this recommendation to another person. Why do you have to show it to another person? Because it's a independent double check, right? So it's independently double checked, meaning that the other person needs to see the advisor, right? They can't just trust you like a pinky promise is 1.4. Promise me, don't you know you don't trust me, bro? Right? So it needs to be, they need to be able to see what it recommended, and then they are going to then put it in the, and they're gonna put their name attached to the name there, right? So your your insulin titration, all right? So what you're gonna put your name in there, and then they're gonna put their name, right? And they're going to then, sign it off, right? You're not gonna convince them. You're not gonna say, hey, it's 1.4, it's 1.4, see my pump, see this pump, it's right here, it's 1.4, you're gonna stand in front of the pump, and you're gonna say, I can put your name right there, is that cool? And it's signed, what's your password? Okay, got it, right? So that's called coercion, right? Or it's called being, that's confirmation bias, right? That's how horoscopes work, right? They say, hey, you're going to have a day where there's cars on the road. It's like, oh, well, gosh, well, there's cars on the road today. And there's traffic in LA. So it's like that's confirmation bias, where someone is going to what they expect, right? So, hey, do you know that there's a lot of ice cream sold in summer and there's shark attacks in summer? So that means that shark attacks must cause ice cream sales. That's what happens, right? So we know that there's different things, and we want to have independent verification of what's happening, right? So all you're doing is saying thank you to them, right? You're not telling them it's 1.4, it's 1.4. Okay, you hear me? It's 1.4. That's not what you're doing. You're trying to make them assess, like, oh yeah, you got 1.4 infused in there. That's what your computer says. I'm gonna go ahead and sign this off for you. Okay. What else? Sometimes it might be really, really weird. It's like, hey, hold the drip and give D10 push, and then give a little D5 water bolus and all these other things. It's like, well, maybe there might be some issues, some situations where, like, your patient getting an NPO. The computer doesn't know your patient's going NPO, so you have to adjust for that, right? So that's kind of more like critical care insulin. For DK, they're going to be NPO to begin with. All right, so independent double check process. You show the advisor, show them the pump, and you can get them loaded up in iView, and they're going to then sign it off for you.